and where I immediately switch to the conversation over complex cases with expert faculty, panelists, Dr. Colombo, Dr. Faraj, Dr. Kearney, Dr. Magdi, Dr. Reitman, Dr. Sanjeev Sharma, Dr. Singh, and Dr. Sutton can stay up. And due to the fact that we're about running into 20 minutes late, we cannot be more than 15 minutes late. I would like to start Dr. Sanjeev Tayal with my worst vascular access case. Everybody, 5-minute presentation, please, in order to have all 8 present. 5 minutes.
Thank you. All right, guys, thank you very much. We'll get started in the interest of time. All right, these are my disclosures. So this was a case of a 78-year-old gentleman, and this was actually a case that I had proctored, but I take responsibility for. They had a pretty extensive past medical history: hypertension, hyperlipidemia, type 2 diabetes, chronic obstructive pulmonary disease, prior CVA. And as you can see, they had a prior CABG with REMA and LEMA. They had also had significant peripheral arterial disease with a history of Lauritia syndrome, and subsequently undergone a right axillobifemoral bypass in 2015. They had also had a pretty significant carotid artery stenosis with a carotid endarterectomy and residual carotid artery stenosis on the other side. The team I was asked to proctor was actually a team in another state that had very little case experience. They had a total of 25 cases. The patient didn't want to go to another institution. We had reviewed this film and kind of looked at it. And there you can see the femoral angiogram, and you can also see the abdominal angiogram, so it is very consistent with Lauritia syndrome. We evaluated him both by CT as well as angiography to look for possible alternative access sites for his transcatheter valve replacement because he had severe AS. You can see that there is a pretty significant carotid artery stenosis, as well as the coronary angiography is shown right here, showing a relatively patent circumflex. The LEMA to the LAD is, sorry, it's not advancing, is patent. Here's a angiogram showing patent right axillobifem as well as a patent REMA, and you can see that the LEMA is also still patent. So overall, after reviewing this, the patient wasn't felt to be a good candidate for transcaval access because the aortic caval distance was greater than 10 millimeters. They weren't really comfortable with a transapical or intrathoracic approach, just based on some calcification in the ascending aorta, as well as the patient's history of pretty severe chronic obstructive pulmonary disease. On the CTA, you can see that there's pretty significant tortuosity of the right subclavian, which made it not a great candidate for right axillary access. The left, however, was a relatively large disease-free vessel with a pretty significant bend here that was measured around 90 degrees, but felt to be somewhat amenable to a percutaneous axillary transcatheter valve replacement. So here you can see we have biradial access with the 6 French pigtail advance from the right radial. You can see our wire is down from the left wrist. So what we did is we obtained radial access and then basically took a picture through an 018 wire with a peripheral balloon on top of it to mark our angiography. Our access point is going to be medial to the humeral head and basically proximal to the subscapular artery. So you can see access was obtained appropriately at the right angle, just in that exact location with a micropuncture technique. And then subsequently, we went on to advance the transcatheter valve. Now, as soon as the sheath went across the IMA, the patient became progressively hypotensive, started developing some intermittent ventricular tachycardia, and actually went into frank ventricular tachycardia. However, due to all the tortuosity, what you can actually note, and this was kind of noted more retrospectively than not, is that in the setting of having severe tortuosity, the balloon that's mounted on the balloon balloon expandable valves had slid forward. So in the process of actually inflating the balloon ruptured, and so the balloon was only partially expanded and unable to be completely deployed after that. The patient actually developed frank cardiac arrest at this point, and then CPR was initiated. So the operators then kind of really freaked out and pulled the device back without being able to do anything else. And so you can see that the valve is now stuck in very close proximity to the IMA. So CPR was continued until it was actually pulled back a little bit further. And that was facilitated by the use of a peripheral balloon. However, despite that, we were unable to withdraw the balloon further. So it was basically pulled until the catheter separated itself from the transcatheter valve. Here you can see the unfurling of the THV delivery system, and you can see part of the nose cone here. Surgery was called, and basically a balloon tamponade was obtained proximal to this. You can see the device was excised. You can see part of the intima of the tissue kind of attached to it. And this was the angiogram that was performed immediately after surgical repair of that area and excision of the valve. So really, in summary, basically, some of the key points that I want to highlight is just because you have a hammer doesn't mean that everything is a nail. And experience really goes a long ways in terms of doing complicated cases like this. In the transcatheter space, whether you're coming from the femoral approach, axillary approach, it doesn't matter. One steep angle is bad, but two is generally a terrible idea. Always be mindful of balloon alignment, and regardless of the situation, stick to basics. I think retrospectively, the left carotid probably would have been a much better approach, but I think it also depends on operator experience, team experience, and familiarity with the process and procedures. Thankfully, this patient did survive, but had a pretty prolonged hospital course and was sent to rehab, recovered, but then later opted for conservative management. Okay. Thank you.
Wow, this was a tremendous case. Congratulations. I don't think we have any comment. Anyone has a brief comment? I think it is what it is. It's a really rough double. I'm very surprised everything that it was actually able to detach. And what do you think once it pulled back? Why do you think the tachycardia? The patient was in a lot of tachycardia, this, that, and then after you pulled everything out, this kind of stopped. Well, what do you mean? How did the patient survive the non-valve operation? I mean,
So
status.
I think the THV was actually pulled and the delivery system was pulled back beyond the IMA because I think the patient was developing ischemia related to occlusion of the IMA, which we thought was probably not going to be that significant given the diameter of the subclavian in that area.
Yeah.
Plus they had a patent rema and a circumflex, but sometimes I guess more people are sensitive to that.
All right, great. Excellent. Congratulations.